Great, great, great. So thank you so much, Sujandadi, for inviting me for being a part of this instruction course. And it's really an honor to be sharing the stage with Ramanjit Madam and Dr. Chandima also. So I'll just talk about gonoscopy, UBM and ASOCT very briefly related to angle evaluation. Glaucoma, as we all know, Sujandali is already highlighted that in Indian perspective, we do have a higher prevalence of angle closure glaucoma, and angle closure glaucoma definitely has a higher prevalence of blindness compared to open angle glaucoma. And as she was really mentioning that this blindness in angle closure glaucoma actually is a preventable cause of blindness. If we do a timely gonoscopy, we detect closed angle, we do a iridotomy, most of these patients will never develop angle closure glaucoma. So this is one of type of blindness which can actually be prevented. But we are having so many webinars, so many meetings. Still, I believe most of patients in India are still treated without gonoscopy, and there are multiple reasons for it. One of the reason I believe is the reason that we still using this 2-mirror and 3-mirror gonoscope. And I tell you why. Previously, when I was trained in gonoscopy, I was using 2-mirror, 3-mirror. It takes more time. It's a little cumbersome and messy. And what happens, in a busy OPD, you tend to avoid doing gonoscopy. But when we switch to a 4-mirror gonoscope like a Sussman or a Poshner type, where you don't need any coupling gel, it's very quick, comfortable, and you end up doing much more gonoscopy, but it is more informative compared to a 2-mirror or a 3-mirror gonoscopy. Now, who needs gonoscopy? In Indian perspective, ideally, everyone needs a gonoscopy. But maybe practically it is not possible at this moment. At least we have to ensure that every glaucoma patient should have a gonoscopy done. Every patient with a family history of glaucoma, raised pressure, trauma, pigment dispersion, pseudoexfoliation, we should be doing a gonoscopy. There are certain clues which we can get during a slit limb evaluation, for example, say glaucoma flecken or area of pupillary of atrophy, cucumber spindles, and pseudoexfoliation, which will give you an idea that this patient definitely needs a gonoscopic evaluation. The Van Harris test is a good test for screening shallow chambers in a busy OPD, but it is not a replacement of gonoscopy. To do iridotomy, you should recheck by gonoscopy before you decide whether the patient needs an iridotomy or not. In gonoscopy, we all know that room should be slightly darkened to reduce meiosis-induced opening of the angle. Patient should be looking in the primary gauge. We should use low but adequate illumination. This is a small video which I have prepared to show that actually a gonoscopy and applanation doesn't take a lot of time. Like this particular patient, we have already used a paracane and fluorescent strip. Now we are doing an applanation tonometry in one eye. Then in the second eye, you can see the whole video is actually a 1-minute video. Once you have done a applanation tonometry, you are using a 4-mirror Poshner type of gonoscope. And we always instruct our OPD assistant to switch off the light. So you can see it's a darkened room. We have reduced the illumination. Since it's 4-mirror, you don't need to rotate. Just look up, down, right, left, and you can get an idea about the angle status. Similarly on the other eye also. So the whole process actually takes 1 minute. We should avoid putting too much of pressure because it leads to false opening of the angle. You can see these Descemet fold, which is indicating that we are probably putting too much pressure. Also, centration is very important. For example, in this case, you can see if you slightly decentered, the air may enter and can lead to problem in the visibility. So gonoscopy needs a bit of practice, and with practice, definitely all of us can master this technique. Another reason why we should switch to a 4-mirror gonoscope or an indentation gonoscope, because here you can differentiate an apposition and synechial closure. And as Suchandadi was mentioning in the last presentation, the recent definitions of angle closure disease, it is important to understand where you have synechial closure and where you have appositional closure. Because of that, you can classify the patients correctly. I won't go into detail of these structures. Coming to grading, I think there are a lot of grading schemes available, but what is important that you just write the structure, it is visible in each quadrant before and after compression, and any other obvious abnormality which you can see. Quickly about some clinical example, you can see all the structures are visible here. So an open angle, this is a closed angle. You can see the corneal wedge is just meeting at the edge of the iris. None of the structures are visible, so it's a closed angle. It's another patient with closed angle where on compression the angle is opening up. This is a patient where the angle was closed. Post iridotomy, you can see these points synechial. So it's a primary angle closure patient where the angle has partly opened up. In plateau iris syndrome, even after iridotomy, sometimes the angle will not open up. You may need to compress. And these cases, often you see this typical double hump pattern or a sine wave sign, what indicates a plateau iris configuration. Here comes the role of imaging also. UVM is a very good tool to confirm plateau iris because it can show these anteriorly positioned ciliary body. UVM is also good for cases like these. These type of humps are not very rare if you're doing a routine gonoscopy. Mostly they are because of iridoceles cyst, but sometimes it can be a tumor also lying behind it. Suppose you want to do a penetrating keratoplasty in a patient like this. In these cases, UVM can be very useful to assess the angle, also to see what is the extent of synechia, what is the lens status before you plan your surgery. Coming to ultrasound biomicroscopy, it is a high frequency ultrasound. It can be done in supine or sitting position. The biggest advantage of UBM is that it helps you to image that elusive iris diaphragm ciliary body complex. That is something previously we had no investigation where we can actually look at that ciliary body pars plana area. So it has got its own clinical application. For this is a normal scan. You can differentiate a closed and open angle. Here you can see the scleral spur is opening into the anterior chamber, so it's an open angle. In this another image, the scleral spur is covered by the iris, so it's a closed angle. It also helps you to understand the pathophysiology of glaucoma. For example, if this is a closed angle, you can see on UBM also there is iridotrabecular contact. Once you've done a PI, the angles open up. So it gives you more idea about how the disease is working. It can also be used for quantification, but then that is mainly used for research purpose, not much useful for day-to-day clinical practice. There have been multiple studies comparing gonio with UBM or gonio with anterior segment OCT. Most of them have found to have good correlation, but both in UBM and anterior segment OCT, it has been seen that angle appear to be narrower compared to what we see in gonoscopy. But if we have a discrepancy, the gonoscopy will always be the gold standard when it comes to deciding whether the patient needs an iridotomy or not, or whether it's open angle or a closed angle. In pigmentary glaucoma, UBM is extremely useful to show the iridozonal contact. So these are the patients where you can consider going for a iridotomy. Unexplained hypertony, you can see the supraciliary effusion, which no other investigation can actually pinpoint that area of supraciliary effusion. Plus patients with cyclodialysis cleft, UBM definitely is better compared to gonoscopy in detecting these clefts. Also post-surgical shallow chambers with malignant glaucoma, you can actually see this flattened and anterior rotated ciliary body, which is a diagnostic test for malignant glaucoma. So these are certain cases where UBM definitely gives you an extra information compared to a gonoscopy. Topiramate induced bilateral angular closure, UBM is diagnostic. You can see the supraciliary effusion, you can confirm it, plus post-treatment, how it is resolved, that can also be seen very nicely on a UBM. Coming to anti-segment OCT, anti-segment OCT uses 1310 nanometer wavelength. This is an optically based imaging system. So in this case, it has also evolved over years from a time domain, Visante OCT, to spectral domain, and now we have got the swept sword OCT. In this case also, scleral spur is a very important landmark. When it opens in the anterior chamber, it's an open angle. If it is covered by the iris, this is regarded as the closed angle. Anti-segment OCT also gives you an idea about the anatomy of the angle, plus also helps you to understand the pathophysiology of glaucoma, for example, an open angle and closed angle. But if you can see here behind the iris, that is the ciliary body in pars plana area, cannot be imaged in a case of AS OCT because light cannot penetrate through pigmented iris epithelium. It's another patient pre and post iridotomy. You can see how the angles have opened up. Pigmentary glaucoma, you can see this concave iris pattern on an anti-segment OCT. In AS OCT also, you can quantify the structures and can see how the patients are changing over time. Again, that is more commonly used for research purposes and for studies. The certain advantages of AS OCT over gonoscopy in UBM: one, it's very, very rapid. You can do in sitting position, and it's a non-contact procedure, so extremely comfortable for the patient. But as I've already mentioned, you cannot image beyond the posterior pigmented epithelium of iris, so a malignant glaucoma or a plateau iris syndrome or even a zonal assessment cannot be done with the AS OCT. Quick comparison between UBM and AS OCT: UBM is ultrasound compared to optical, which is anti-segment OCT. UBM is contact compared to AS OCT, which is a non-contact procedure. UBM needs training. It's not easy. Sometimes you can injure the cornea. You need to practice. Compared to anti-segment OCT, is far more easier, less demanding compared to UBM. So to conclude, I'll say there are multiple investigations ASOCT, imaging, UBM, but most of the recommendation, whether it's the EGS or the American Academy, they have highlighted that all these anterior chamber imaging are useful as a supplement to gonioscopy. They cannot replace gonioscopy for a routine evaluation. So gonioscopy is still the gold standard when it comes to evaluation of your ankle. Thank you so much.